Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Regis Pifol-T-Letor from Paris, France, and he's going to lecture us on non-transplant treatment of aplastic anemia. This webinar is brought to you by Mumbai Hematology Group, supported by BSV Bringing Life to Life, and managed by Perfect Square. I thank Dr. Saswata Banerjee and team BSV, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Dipti Rani Samanta from Cuttack. Our guest speaker for the day, Dr. Regis Pifol-T-Letor from Paris, France. All our discussants who are themselves very eminent hematologists, and you participants for sparing the Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 7th of September 2024, from 7 p.m. Indian Standard Time, we have Dr. Avinash Gupta from Varanasi speaking to us on flow cytometry in evaluation of hematopoietic neoplasms, a pattern-based approach. And the following day, that is Sunday, 8th of September 2024,
Internet connection
7:30 a.m. Indian Standard Time, we have Dr. Akili Garg from Gwalior speaking to us on chronic myeloid leukemia, challenges in clinical practice. Let me introduce our discussions for the day, and they are very important personalities all over India. To start with, we have Dr. Abhijit Baheti from Dinanath Mangeshkar Hospital, Pune, Dr. Aishwarya Raj from Gujarat Cancer and Research Institute, Ahmedabad, Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad, Dr. Akash Khandelwal from Action Cancer Hospital, New Delhi, Dr. Alka Khadwal from PGI Chandigarh, Dr. Amrita Saraf from Sir Gangaram Hospital, Delhi, Dr. Ankit Rayani from Cure Hematology Oncology Clinic, Ahmedabad, Dr. Aryan Jain from PGI Chandigarh, Dr. Pradeep K. Reddy from PGI Chandigarh, Dr. Prashanta Bhatt from KMC Hospital, Mangaluru, Dr. Preeti Mehta from SRCC Children's Hospital, Mumbai, Dr. Rajiv Dey from NRS Medical College, Kolkata, Lieutenant Colonel Dr. Ranjit Matthew Varghese from Command Hospital, Pune, Dr. Sanjukta Rao from St. John's Medical College Hospital, Bangalore, Dr. Satish Kumar A. from Manipal Hospital, Bangalore, Dr. Suprakash Sanyal from Fortis Hospital, Mumbai, Dr. Suma T.L. from HCG Hospital, Bangalore, Dr. Tulika Sheth from AIMS, Delhi. Now it's a time to introduce our special guest and chief guest for the day. We have with us Professor Dr. Dipti Rani Samanta from Cuttack. Dr. Dipti Rani Samanta is Professor and Head, Department of Medical Oncology at Acharya Harihar Postgraduate Institute of Cancer, Cuttack. Her areas of interest are hemato-oncology, breast cancer, and has a teaching experience of 19 years in Acharya Harihar Postgraduate Institute of Cancer. She has about 35 national and 18 international publications in index journals. Her fellowships include Indo-American Cancer Association Fellowship 2009, Fellowship at MD Anderson Cancer Center, Texas, USA on multiple myeloma and lymphoma, member of ASCO, ISMPO, ISO, Indian Association of Hematology and Transfusion Medicine, and Indian Cooperative Oncology Network, AGOI, that is Association of Gynecological Oncologists of India, Odisha Society of Oncology, Indian Society of Clinical Research. It's my privilege to welcome Dr. Dipti Rani Samanta to inaugurate our webinar and give some words of wisdom. Over to you, ma'am.
Thank you. Am I audible?
Yes, ma'am. Please go ahead.
Good morning, everyone. I am delighted to serve as the chief guest for today's webinar organized by the Mumbai Hematology Group. As the professor and head of the Department of Medical Oncology at Acharya Harihara Postgraduate Institute of Cancer, Cuttack, Odisha, my journey in this esteemed institution has been both challenging and rewarding. When I first joined, our department had just 2 faculty members and 32 beds. Through persistent effort and dedication, we have now expanded our team to include 3 faculty members, 3 resident doctors, and a total of 88 beds for adult patients, along with 18 beds dedicated to pediatric care. I have been privileged to work under the guidance of distinguished mentors such as Professor S.H. Arbhani, Professor Purna Kurkure, Professor S.T. Banwale, and Professor Reena Nair in Tata Memorial Hospital, Mumbai. Their wisdom and mentorship have greatly influenced my professional growth, fostering in me a positive attitude and a clear vision for the future. My career has also been enriched by international experiences, including the Indo-American Cancer Association Fellowship at West Virginia University, USA, under Dr. James Abraham. This opportunity inspired me to establish one of the most advanced daycare units at our institute, now recognized as a center of excellence in our state. Furthermore, my fellowship at MD Anderson Cancer Center in Houston, Texas, USA, under Professor Jatin Saha, has significantly enhanced the quality of care we provide for hematolymphoid malignancies. This year marks another milestone as we admit 2 students into DM Medical Oncology program with 6 new assistant professor positions created to further strengthen our department. While my journey has been marked by hardships and struggles, it has also been a testament to the importance of resilience. The key takeaway I wish to share with you is that we must never be discouraged by the challenges we face, but instead remain hopeful and steadfast in our pursuit of excellence. For the growth of any institution, it is essential to uphold the values of discipline, dedication, and devotion. Moreover, fostering inter-institutional collaboration is crucial for advancing both clinical trials and translational research, which is a definite need of recent era. Here I conclude and look forward to a fruitful and enriching webinar. Thank you. Thank you, Professor Dr. M.B. Agrawal, for the opportunity, and Dr. Amit, and all members for kind attention. Thank you again.
Thank you, ma'am, for that great words of wisdom. And thank you for accepting our invitation as our chief guest for the day. I shared my screen once again, sir. You'll have to, sir. Sir, please unshare your screen once. Yeah, thank you, sir. So now it's a time to introduce our guest speaker for the day. We have with us Dr. Regis Peffault de Latour from Paris, France. Dr. Regis Peffault de Latour received his MD degree from University of Paris at Lariboisière in 2003 and his PhD degree in immunology from the Pasteur Institute in 2006, where he worked on regulatory T cells in graft versus host disease after hematopoietic stem cell transplantation. He was trained in hematology at Paris hospitals and did his postdoctoral fellowship at the Hematology Branch, National Institute of Health, USA, from 2008 to 2010 on aplastic anemia and paroxysmal nocturnal hemoglobinuria. He obtained his tenured professorship position in 2014. He is responsible of the French Reference Center on aplastic anemia and PNH, as well as of the French Organization for Rare Hematological and Immunological Disorders since 2016. He is currently the head of the Hematology and Bone Marrow Transplant Department at St. Louis Hospital, Paris, France since 2022. His research interest focuses on bone marrow transplantation, bone marrow failure, and paroxysmal nocturnal hemoglobinuria. He is the principal investigator of many research studies on bone marrow failure at national as well as international level. He is the author as well as co-author of more than 350 papers quoted in PubMed and is a regular reviewer for journals like New England Journal of Medicine, Blood, Hematologica, British Journal of Hematology, Biology of Blood, and Marrow Transplantation and Bone Marrow Transplantation. And today he's going to lecture us on non-transplant treatment of aplastic anemia. Well, thank you so much. Over to you, Professor.
Thank you very much for this very kind introduction. I guess you see my slides now?
Yes, sir. Perfect.
Okay, great. So yeah, it's my pleasure to be with you today to share with you this this talk. It's always very difficult because you have to balance between transplant and not transplant approach. That's the reason why I will probably put in perspective the treatment. So those are my disclosures for this talk. So at the very beginning, it's more than introduction than a talk, I'd like to highlight few points on the diagnosis of aplastic anemia, because before treating, we have to keep in mind that this disease might be inherited, and what I would present to you, it will be for acquired. The other thing that we have to think about is when we should start a treatment, which is not always clear, and then afterwards, we'll go first line until refractory patients, and again, putting in perspective when patients should be transplanted, even if the question of today is just a non-transplant patients. So first of all, I guess that we're discussing a disease where the pancytopenia is constant. We are facing microcytosis for patients with acquired or inherited disorders. There is no difference between them. The thing that might sometimes be helpful when you just met the patients is obviously the lymphocytes that might be preserved in case of acquired aplastic anemia, while sometimes you have more a lymphopenia in terms of inherited. In aplastic anemia, most of the time, the first lineage is thrombocytes, and the first entry in the disease is a thrombopenia. And that's quite important because that might help us to make you the difference between myelodysplastic syndrome, which is a differential diagnosis, and especially the apoplastic MDS, where most of the time the first lineage is anemia, with hemoglobin level decreasing while the other stage are okay. All single patients with aplastic anemia must have obviously a mere aspiration to do the diagnosis, showing that there is no blasts, no abnormal cells in general. We cannot speak about aplastic anemia without doing a bone marrow biopsy. That biopsy will show to you the cellularity, which is decreased to less than 30%, and which is part of the diagnosis. And then you may have some other abnormality in cells that are completely usual, yet should not read out the diagnosis with the dyseritopoiesis, and especially if patients have a PNH clone, and also some mast cells with a lymphoid hyperplasia, because this is the pathophysiology of the disease with a T cell directed action, plasma cells, and macrophages. So here is represented our approach in France. We are basically writing some guidelines every year. And those guidelines are the basis for us to treat, to manage and to treat our patients. Those guidelines have been recently translated in English, so they are available. So if you want me to send to you after the talk, there is absolutely no problem, and my pleasure. So when we have done the diagnosis of aplastic anemia, then we are focusing on the difference between inherited and acquired. And as you can see here, if a patient has a PNH clone of more than 1%, then we are going straight forward to the diagnosis of acquired aplastic anemia. If the patient has no PNH clone, then in adult patients, it's very important to come back to clinic and to see if this pancytopenia was acute, means in less than 2 years. Is there any family history in those patients that might make you think that there is a gene that is causing BMF in other member of the family? We are looking for hemoglobin F and alpha-fetoprotein that are easily to dose, and that might help to make the diagnosis of inherited disorder. And the other thing that we should not forget, that we are clinicians. So we have to go to the physical exam to our patient. In the case of acquired aplastic anemia, there is absolutely no abnormality that you can find doing the clinical examination. And for those reasons, if there is no PNH clone, but you have a real diagnosis of aplastic anemia in an adult patient, then we think it's an acquired aplastic anemia. For the pediatric patients, we are more aggressive in terms of exploration. And at the very beginning, we were doing always a breakage test to see if the patients might have a Fanconi anemia. But right now, I should confess that we are proceeding to a gene panel looking for BMF genes, about more than 160, to be sure that the patient is not presenting an inherited acquired BMF. And then we are proceeding to the diagnosis of acquired aplastic anemia. So this first point was very short, but I think we cannot speak about treatment if we are not autoimmune-mediated aplastic anemia. So now the second point is when to treat. So we don't all agree on this worldwide speaking. I guess that we all agree that if a patient is presenting a very severe aplastic anemia, and of course a very severe, then the patients need a treatment. So that's very important, and basically this is obviously agreed by everybody. On the other side, you have the patients with moderate signs of aplastic anemia. So those patients, you know they have aplastic anemia, you know that they have acquired or inherited, that's exactly the same way of doing, but they are not you don't know if you should treat or not. So what we're looking on is transfusion. All the patients is transfused, meaning he has moderate aplastic anemia, but he still need an hematopoiesis support, and then you have to treat him because obviously the patient is suffering from aplastic anemia with the consequences on the management. On the other side, if the patient is not transfused, if the patient basically has moderate signs and living well, then you're just following up with CBCs, I would say 3-4 times a year, with marrow sampling every 18 months to be sure that the patient is not going through a clonal evolution. So now, the last thing is, of course, you should not lose or follow up those patients, but it's more easy to say than to do. So now, this is the main algorithm, and we are entering in the main topic of my talk. How should we treat outside transplantation our patients? So again, I cannot not speak about transplant because this is really a balanced approach. So as you can see here, now we're facing a patient with a well-identified acquired autoimmune-mediated aplastic anemia. And of course, the first question that rises up is if these patients have a sibling donor or if his age less than 40 years. If it's the case with young patients less than 40 years of age and sibling donor, you have to go to transplant. We all agreed on that. There is no way to non-transplant treatment, and that's the best treatment of our patients so far. If the patient has no sibling and is aged more than 40 years, then we are discussing, of course, immunosuppression. And there is a very specific situation obviously that we need to address is if a patient have a match unrelated donor available. So at the moment, this is a highly discussed topic because for pediatric patients, it looks like if we have a match unrelated donor, we should go to transplant straightforward and not go through the immunosuppression. Again, if you think you can have a match unrelated donor very quickly, with a lot of insurance, meaning that you have, let's say, a good probability of match unrelated donor, means 5 match unrelated donor identified, then you could proceed. On the other way around, it's always very difficult to wait 2 months before doing a treatment in a patient, especially in a patient that's going to be transfused, might get immunized or might get infected, and in the end, not might be transplanted. So this is a question, this is a discussion, and we can come back to it after the talk. So now, of course, we are coming to immunosuppression. So while the reference treatment for many years has been Ors ATG plus cyclosporine alone, this is a French experience before a thrombopag was available. This is a real-world study. This is about 500 patients, and just to show what we're expecting on a real-life basis. So as you can see here, basically the message is the overall response is obtained at 6 months. You see the cumulative incidence of the response. You see that we may gain some response from 3 to 6 months. And the other thing that we have to keep in mind is that patients with moderate aplastic anemia are responding quicker and better. So this is also for this reason that for moderate aplastic anemia, we might avoid L-thrombopag, but we'll see this in a minute. The other thing that we have to keep in mind is that complete response in this disease was very rare when we got only the association of Ors ATG plus cyclosporine. We got about 10%, 15% of patients who were coming back to normal counts. And the other thing is that since 40 years before L-thrombopag was available, the patients were about 30 to 40% to be refractory, with the questions that you have to keep in mind, and that's something we'll discuss later on. If the patient is refractory, are you sure you have the good diagnosis? Because you might have missed a diagnosis of inherited disorder that might the patient's not responsive, obviously, to immunosuppression. And on the other way around is that we know that 10 to 15% of patients with aplastic anemia are evolving to clonal evolution. And again, that's something that might in your hand have appear and the patients presenting clonal evolution. So this platform of force ATG plus cyclosporine has been tremendously modified since 40 years. You see all the trials that has been done to try to improve, to try to increase, to try to replace. We try steroids with obviously no effect. We try to replace ATG by cyclophosphamide, moderate dose, high dose, and has already been or inefficient or toxic. There have some trials that has been stopped because of toxicity. We saw that since it's a immune-mediated disease, we should add immunosuppression, and then this immunosuppression might help to control the disease. So we added mycophenolate mofetil, we added sirolimus in a randomized way. It was driven by NIH. The PI was Phil Scheinberg, and it didn't change anything. And finally, even growth factors in a randomized way at the European level did not change anything. So that's when the thrombopoietin receptor agonist came to the field, and I guess this was a milestone in the non-transplant treatment of aplastic anemia. So those are the TPO receptor agonists that we have access to at the moment. I would say that in Europe, we have access to romiplastim and eltrombopag. Avatrombopag is not available for us. You see that romiplastim is a Fc peptide fusion protein, while eltrombopag is a non-peptide small molecule. So they are not acting the same way, and basically they are stimulating stem cells, at least is what we think. So first of all, we have to consider that at the very beginning, there was most of controversies worldwide because experts were really balanced by using those thrombopoietin receptor agonists in aplastic anemia, because we all know that the TPO level was outstandingly elevated in this disease. And so there was no reason to add more in a disease where thrombopoietin was already high. However, there was some clues to think that the thrombopoietin was acting on stem cells from the bench side, on in vitro cells, but also from nice model showing that the TPO knockout mice have a reduced number of stem cells. And as you can see here, the entire hematopoiesis is impacted by TPO, and that might support the role of TPO receptor agonist in aplastic anemia and all other myelofibrosis disorders. And another thing that was coming from the observation is that patients with inherited mutations in MPL or THPO, they may involve to bone marrow failure. So that might be possible that TPO was creating the problem. So as you can see here, there was the first two studies who finally get solved that question and showed that patients with highly refractory aplastic anemia might respond to eltrombopag. So that was done at NIH. I was privileged to be there at that time and shows those patients, there were 25 who were outstandingly severe. Those patients had received already many clinical trials, and they were highly refractory, transfused loudly. And as you can see, 44% of them were responded and were becoming transfusion independent. And then this study was extended, published in Blood with more patients. And you can see that when we added 18 patients, reaching 43 patients, 40% of them had a successful taper of eltrombopag and sustained multi-lineage response, most of them being transfusion independent. So that was basically a revolution in the field, because we got a treatment that was able to get a response in 40% of our patients, while before in refractory patients, we were more expecting 15 to 20% of response, where we were challenging the patients again with immunosuppression courses. And the thing that was really striking using eltrombopag was the fact that we are not, of course, acting only on thrombocyte. You could see here there was a multilineage response with some patients experiencing a trilineage response. You could see here that 7 out of 18 patients who responded presented a durable multilineage response, where it was showing in the clinical setting that eltrombopag might be efficient in refractory patients. So those are the very important findings in the disease. Bone marrow cellularity, you can see that at pre and post treatment, the marrow was repopulated by stem cells, which is very, very interesting, showing that the patients were responding and the marrow were enriched in stem cells. So the other thing that we found in this setting is that the patients might stop the drugs. So that was also a bit new, that the patients being refractory might respond and then stop, and then obviously possibly exposed to relapse, and we'll see in a minute how many rates of relapse. But the other thing is that it's a drug that was really helpful and with my stop with the patient. I just pointed out here and highlight what we call robust responders. Robust responders in refractory setting are the patients who are reaching 50 giga per liter of platelets, 10 grams per deciliter of hemoglobin, and 1 giga per liter neutrophils at 8 weeks. So this is very important because then we are discussing the same definition. So the patients are responding. We could stop the drugs, but as usual, when you're stimulating the marrow, you might think the patients develop clonal evolution. So beforehand, and again, I think it's very important to know what we are discussing. So the definition for clonal evolution in all what I'm going to show to you after is the chromosome 7 abnormality appearance, a complex cytogenetics, or a diagnosis of myeloid malignancy, MDS, MPN, or AML. This is a high-risk clonal evolution in the context of aplastic anemia. You have also low-risk clonal evolution, those all other isolated chromosome abnormalities, deletion 13q, trisomy 8, or deletion 5q, that are not impacted, mainly prognosis, that should not be an indication for transplant, but that are showing that the patient is evolving slowly to clonal hematopoiesis. So in the studies I presented to you, the results are highlighted here, and you can see that those clonal evolution were quite low. There was about 20% of the entire cohort are reaching this definition of clonal evolution. As you know well, when you compare to historical controls, the level of clonal evolution was exactly the same. So that are the clinical trials coming from NIH. We did also use another TP receptor agonist in French, which is wamiplastim. And I think it's important to make it clear that what we reported in the BMT journal some years ago was with a dose of wamiplastim of 5 micrograms per kilo. And what we do show is that there was only one responder among 14 patients, showing that at 5 micrograms per kilo, you're not expecting a high rate of response in refractory patients using TP receptor agonist wamiplastim. However, there was this very nice clinical trial, nice and clean, coming from South Korea, showing that the dose of wamiplastim that should be used in patients with aplastic anemia should be at least 10 micrograms per kilo. This was a very, very important study showing that like eltrombopag is used at a higher dosage in aplastic anemia compared with ITP. In the context of aplastic anemia, again, wamiplastim should be used at a higher dosage than what we are using usually in ITP, coming from 5 to 10 micrograms per kilo. Then there was a phase 2-3 multi-center South Korea study showing very good response rate. There was the highest response rates obtained in refractory patients with aplastic anemia. And again, a trilineages response with 39% of patients responding at the trilineage level. And they finally confirmed on the long-term data that this ramiplastim approach was effective and safe. So this is, again, to show that we could use eltrombopag as we can use TP receptor agonist romiplastim in that situation. And if you are choosing the good dose, the results should be the same. So I just summarize here all the clinical trials who were done using eltrombopag or ramiplastim. All those trials might be prospective or retrospective, and as you can see, we could expect a response rate between 25% to 85% in refractory patients. And as you can see here, we were, of course, as usual, thinking of using in first line, because if a drug is working in refractory patients, then you might get an input in patients' first line. So the first data generated came from NIH again. The idea was to add at the ATG plus cyclosporine platform the eltrombopag, and to see if you might obtain a response in those patients. There was 3/4 of patients, all naive, all treated with the standard ATG plus cyclosporine, and you see there was 3 schedules of eltrombopag. From day 14 to month 6 was cohort 1. From day 15 to month 3, it was cohort 2, and from the beginning to month 6, it was the cohort 3. So again, two precision when you're going through those data. The first precision is that the definition of response is not the same that we're using in Europe and probably in India. So in other words, complete response, we all agree, a patient with aplastic anemia who is reaching at 6 months more than 100 giga/liter platelets, more than 1 giga/liter neutrophil, or more than 10 grams per deciliter hemoglobin level is considered as a complete responder. On the other way around, partial response, we do not all agree, because partial response in US is not meeting anymore the criteria for severe aplastic anemia. In Europe, partial response is considered for patients who are not reaching criteria for severe aplastic anemia, but also who are transfusion independent. And that's the main difference. And you'll see that in the results, that might impact deeply the results in our patients. And the second message, so the first one was on the definition, the second one is on the complete response. You see that in historical controls, what we are expecting is only 15, I tend to use 10 to 15 in the historical controls of NIH, it was 17%. And the overall response at 6 months, taking into account at NIH that transfusion independence is not considered as a definition for partial response, is about 68%. And then when you come to the core of questions, you see in the term of message that the overall response was outstandingly high, 80, 87, 94% in the score of patients treating with eltrombopag at the top of ATG plus cyclosporine, which compare favorably to the 68% that was observed in historical controls. And more importantly, you see those patients experiencing a very good complete response, 33, 26, and 58%, which is unexpected because I told you most of the time those patients are presenting a non-complete response after immunosuppression. However, those trials were phase 2 trial, so that's the reason why we leaded in Europe the phase 3 trial, this investigator-driven, academic-based phase 3 randomized trial, who was comparing all ATG plus cyclosporine plus or minus eltrombopag in a randomized way. You see that we focus on severe or very severe patients. The randomization was 1-to-1 to receive the reference treatment by oral ATG plus cyclosporine or the same treatment plus eltrombopag, with a duration of 3 months if the patients were obtaining a complete response, or 6 months if the patients were still refractory at 3 months, or not in complete response at 3 months. The primary endpoint was a complete response at 3 months, and then the other key secondary endpoints you're describing here. So the originality of that trial was not only to be obviously a multi-center trial, randomized one, but also because we were biosampling patients baseline 6 months and 2 years after treatment. That was, as you will see, very important in terms of findings. And we were also stratified the inclusion according to disease severity and age, as well as by center to avoid any bias. So you see here the difference between both studies. I would directly come to two things. The first one is the eltrombopag exposition. You can see that in the NIH studies, there was 3 arms of treatment, while we decided to expose the patients the less we could to eltrombopag, means until 3 months, and then 6 months only the patients were not in complete response at 3 months. And the other thing is in red, you see that partial response is defined outside transfusion status in the US study, while for the European study, we were discussing transfusion independency as a masterpiece of the partial response definition. So again, definitions, I'm sorry to be so sticky on it, but that's very important to speak about what we know. So complete response, everywhere is the same, we all agree on. Partial response, transfusion independence in the European study, and non-responders for the other ones. Clonal evolution, we already spoke about. And the primary endpoint in that study was to increase the complete response from 7% 3 months to 21% in the experimental arm. It was about 200 patients. So this is basically this position of the trial. You see that we had 6 European countries. We included patients in 4 years. The median follow-up at the stage the data were consolidated was 18 months, but now we have 2 years. That has been presented at EBMT, and that will be presented at HASH. So you see that 205 patients was registered. There was 3 patients who could not make the randomizations for DAS because this is a severe disease, but also for misdiagnosis, there was 1 patient. He was my institution, basically. So we have to disclose, who was diagnosed with sarcoidosis. Finally, 202 patients were randomized. There was misdiagnosis retrospectively that might us exclude 2 patients with moderate aplastic anemia and 2 patients with MDS and 1 with AML. 1 with MDS, 1 with AML. And finally, 197 patients were analyzed with a balanced distribution between both arms. This is a characteristic. So we could not say most things like that. The median age is the one that is expected in this population of treatment, about 55 years of age. That, as you can see, the age was also well distributed, but don't forget that there was a stratifications according to age and center and severity of the disease. And finally, for the PNH clone was basically well distributed between arms. So the primary endpoint was reached. You could see here that the 3 months response was higher in the eltrombopag arm, and the complete response at 3 months was almost doubled, which was significant and makes the study being successful. However, you see at 6 months, the slow rate of overall response was 44.8% in the standard arm versus 71.8% in experimental arm. So a big difference, huge difference between both arms, more than what I was showing to you before. And then it might come to your mind that in the end, it was successful because the standard arm was responding lower, while the experimental arm was responding as expected. However, remember what I told you, we are considering transfusion independency as a masterpiece of partial response criteria. And if now you're using the NIH criteria, you'll come back to what has been published. At 3 months, you see that the overall response in the standard arm was about 66% compared with 76% in the experimental arm. And then when you come to 6 months, you come to 66%. Remember the 68% published by NIH, so it's exactly the same response rates with 78.7% in the eltrombopag arm. That was significant. So we were showing using both definitions, both discussions, both classifications, that The eltrombopag at the top of 4-ATG plus cyclosporine was helpful, improving drastically his response rates to our patients, and is now the reference treatment for patients with severe or very severe aplastic anemia. So what about relapse? So this is the data that has been published in Blood by NIH in 2022. You see that there was higher rates of relapse in patients who was not using a cyclosporine maintenance, because at NIH they were thinking that eltrombopag might offer a short, quick time of cyclosporine, and they were stopping cyclosporine at 6 months. That was a mistake. And now they are continuing cyclosporine until 2 years, like we are doing in Europe. And as you can see on the right side, you see there was higher rates, a little bit higher rates of eltrombopag relapse, but it was not significant. And the relapse rates were very similar between eltrombopag and not eltrombopag arm, because we are continuing systematically cyclosporine until 1 year, and then we are decreasing and stopping until 2 years. So that's important message here, is that of course you're adding eltrombopag until 3 months if the patient is in complete remission, until 6 months if the patient is not in complete remission at 3 months. But please, the cyclosporine should go full dose until 1 year, and then from 1 year to 2 years you're decreasing and tapering slowly and stopping at 2 years. So you see those conditions that make you relapse. So there was obviously the eltrombopag stopped. That was shown also in the European study. But you see that the cyclosporine was also playing a role, and was less obvious in our study because we were decreasing very slowly. The other thing that you have to be aware of is that the first lineage associated with relapse is the thrombocyte. And the patients are most of the time entering into a relapse state by thrombopenia. So this is something I might alert you when you're treating those patients. And the second thing that was coming from NIH is showing that those patients might be treated again. This is something we published, and we report also at EBMT, but it's not published yet. I hope it will be submitted soon. But for NIH, it was published. You see there were 61 patients who relapsed, and they were exposed again to cyclosporine alone, 27, or cyclosporine plus eltrombopag, 31. And you see that the rates of response were quite high. So clonal evolution is a concern, and in the RISE trial, we observed 4 patients who presented a morphological clonal evolution, and as you can see here, those patients were well balanced between arm A and arm B, and it was something that was expected. In other words, there was no difference between arms, and the overall clonal evolution stage was not something different than was expected. I told you I didn't have time to enter into detail, but this is the most important slide from the RISE trial. It's the fact that we did analyze at baseline 6 months and 24 months the myeloid cancer gene mutations, showing that in this disease, 30% of patients had myeloid cancer gene mutations at diagnosis, 60% after immunosuppression, you see at 6 months, which was maintained at 24 months. So that's very important, because it's showing that aplastic anemia is not MDS, and you might add some mutations in that disease that are not classifying you as a cancer. And that's outstandingly important, because we should not indicate any transplantation on that mutations isolated, because that might happen, and this is something normal in the context of aplastic anemia. If you come now to clonal evolution with the definitions I was showing to you before, you see that here the cumulative incidence of clonal evolution at NIH was about 15% at 4 years for the overall clonal evolution, and high risk was about 5% versus 10% in the eltrombopag arm at 4 years. So you see, this is a bit what was expected. The only difference with the eltrombopag arm is that these clonal evolution that are expected overall are appearing sooner. You see here, it was about 186 days to have a clonal evolution in the eltrombopag arm, while it was about 777 days in the historical controls. In terms of type of clonal evolution, it was completely expected with the thing that I described before. I'm not going to go into details. And something that is outstandingly important is that those low-risk clonal evolution was transient for some of the patients. And that's quite important to see that the patients should not be considered for transplantations with lower risk clonal evolution, because again, you will probably transplant patients where the clonal evolution might have disappeared spontaneously. So what about kids now and special population? So there is this retrospective study from NIH, and I think that we should not go further, where they compared the association of eltrombopag plus ATG plus cyclosporine in kids versus historical controls. And as you can see here, the overall response was about 72% in the standard treatment arm versus 70% with the eltrombopag arm. So you have no gain of adding eltrombopag in this population. And in terms of relapse, you see that the eltrombopag group was a little bit higher. It was not significant, but a little bit higher. And that also should something be considered in those patients. That's the reason why in kids, we are not using eltrombopag as immunosuppression. We are treating with ATG plus cyclosporine, and then all the patients is responding, and then, okay, we are managing immunosuppression. All the patient is not responding, and then we are basically proceeding to transplant. So one word on all the patients. This is a study I recommend you to read. It was published in Lancet Hematology. It's a phase 2 trial, cyclosporine plus eltrombopag, prospective, with a primary endpoint of overall survival, overall response, at 6 months using both drugs outside ATG use, because we do know that in all the patients, we might not use ATG because of comorbidities. And the main message is on this slide. You see that you are expecting an overall response rate of 46%. This is naive patients, first line, 6 months. And if you're targeting on the less than 65 years of age patients, the 37 you see in the middle of the slide, you see that the overall response was about 54%. So main message on eltrombopag. So first of all, for Asian patients, we have to decrease the dose twice, because you know that there is this enzyme difference, and so we just adapt the drugs. For the hepatic impairment in patients who have some troubles, you should start eltrombopag at a lower dose. What we're doing usually, it's begin at 75 and then looking for 10 days, checking for liver, and then increasing to 150 milligram if the liver is okay and if there are no clinical conditions like abdominal pain or stuff like that. If the patients have some liver dysfunction, then we are beginning at 25 and we see what's going on, and then we're trying to increase slowly. For renal impairment, very important, no dose adjustment, so no worries on that side. So now we're entering in a, I would say, new type of patients. It's the patients who are refractory to the association of ATG plus cyclosporine plus eltrombopag. Not easy. Not easy outside transplantation, because really those patients might benefit from transplant. The first question that you have to raise, I told you before, if I'm not doing a wrong diagnosis. So in other words, when you have a patient refractory 6 months, please come back to your diagnosis, come back to questions, come back to family. Try to see if you did not miss an inherited disorder. And on the other side, when a patient is refractory 6 months, you should also think about clonal evolution. So please, marrow sampling to just eliminate that the patient is not suffering any more of aplastic anemia, but possibly from MDS AML. And then obviously all the treatment you're going to use will be useless. So the question, we don't really know why those patients are not responding. I told you the EBMF. The other thing that we are thinking about is patients who might be, in a way, facing a low number of stem cells. So it might have an hematopoietic stem cells exhaustion. And more or less these questions of inadequate immunosuppression, thinking that if we could use another immunosuppression might be useful. I'm not so convinced, but this is also a possibility for non-response. So when you're thinking about a treatment in refractory patients, you have obviously to consider that those patients are higher exposed to clonal evolution, so they should really be followed up closely at the marrow level. You should think, of course, about age and comorbidities in those patients, because again, the reference treatment for refractory patients is transplantation. And if you cannot proceed to transplantation, it's obviously because of those reasons. And of course, in those patients, this is very risky transplant with a high risk of infection, of rejection, and GVHD. And of course, you look for donors. So second line ATG, well, I'm not going to be very long. What you are expecting, it's around 20% of a response. So you see, when you're exposing again the refractory patients to obtain a 20% of response, NIH speaking, this is NIH studies. So it means that the patients might still be transfused. It's not something that is very motivating. The other thing what we published recently was the use of androgens, probably the oldest drug in the world and the cheapest one, which is very good. That was done by Simona Pagliuca from Nancy, and she was really showing nice results. We know that sometimes it might be helpful. So the setting of that trial obviously was very heterogeneous. It was a real life study, retrospective one on 40 years. But what we could show is that the response to androgens is obtained at 6 months. You see that you have about 50% of patients that might respond, which is not bad. This is a European response, so you're transfusion independent. The maximum dose we could use was about 800 milligram danazol, mostly. The overall survival is not bad. Remember, this is refractory patients, and you see then the transfusion independent curve on the left and the failure-free survival curve on the right. Quite difficult, but anyway, it's an opportunity. The other thing that I'm always saying, and I'm sure I already presented to you these slides, when you're discussing patients, refractory patients, don't miss that we are doing far better in 2024. This is a very old study that was already showing that in 96, 2002, and 2008, the patients were doing better with supportive care only. Just giving transfusion, just giving antibiotics, just giving normal care might make patients live longer. And that the trial, that curve were published before Eltrombopag was available. We are at the moment retrospectively assessing all refractory patients in France at the adult level and the pediatric level. And I can tell you again, we are doing good. We are doing good with those patients. So sometimes not treating is not a bad solution. And you should think twice in older patients where transplant is impossible, very frail patients that repeated immunosuppression or adding drugs might be detrimental. And in the end, just, optimizing the healthcare might be sufficient to offer them some longer survival. So the conclusion, that's probably the TP receptor agonist that revolutionized the field. Now it might be used in first-line patients with the association of FORCE-ATG plus cyclosporine plus Eltrombopag. We are not using it in moderate aplastic anemia because we have no trial to use it. So this is something we might discuss. The patients with moderate aplastic anemia are responding better. So also ATG plus cyclosporine might be enough. So that's the reason why we're not using Eltrombopag at the top of it. We are not using in children, I told you. The response rates were okay. The good thing with Eltrombopag is that we can discontinue the drug. This is manageable. And we can also treat relapse easily. Refractory patients is not an easy path. And honestly, we don't have a lot of treatment at the moment because we are giving straightforward the triple therapy associating cyclosporine, FORCE-ATG, and Eltrombopag. So we are trying to do the best, and at least we are trying. I wrote primum non nocere. We try not to, be more toxic than benefit in those patients. So this is something that we might discuss afterwards. And I think that with that, I'm a little bit longer than expected. I apologize. And thank you very much for your attention, and more than happy to take questions.
Thank you, sir, for that fantastic lecture, throwing light on the non-transplant management of aplastic anemia. That was wonderful, sir.
Thank
And
you.
I request now all our discussants to please put the raise hand sign so that we can start our question answer session. Yes, Dr. Arihat Jain, your question, please.
So, thank you, Dr. Latour. Am I audible?
Yes, please go ahead.
So, my first question is that one of the hypotheses for the refractory or non-responder patients to IST is given as the extreme level of stem cell exhaustion. And that is probably the reason that at least in our setting, where the patients do end up coming late to the clinical care, or there is a significant time from the diagnosis to ATG interval, that our response rates are not as so they are like 50 to 60%. So is there do you suggest is there a way to quantitate the level of stem cell exhaustion, and or maybe is how we can predict a prior whether that patient would respond to IST or not?
So there's a very good question. So we don't have way, because as you know, the marrow is very heterogeneous in aplastic anemia. So when you're doing a marrow punction on one side, you might have a level of stem cells that is a bit less or more than on the other side. That's the reason why in kids we are doing multi-myeloid aspiration. So we don't have a straightforward way to quantitate those stem cells. What we are trying to do at the moment is to use some new techniques with tag of stem cells to see if we could follow them during the evolution, and to see if we might add a quantitative status on this. This is in development with Institut Curie at the moment in Paris. We are trying this, but it's for the moment, it's at the very beginning, and we don't have tools that are able to do it straightforward.
Thank you. Can I ask one or two more questions?
Yeah, please go ahead.
So the other question is that usually that 1% PNH clone cutoff is taken as where we would probably give a suggestion of a acquired versus an inherited aplastic anemia. But a lot of our, and probably that's the cutoff which we use for as a surrogate marker for a predictive of response to an IST-based approach. But a lot of our aplastic anemia patients would have a clone size which is less than 1%, say 0.3, 0.4, 0.8% detected on flow cytometry. So is there a basis of that 1% cutoff, or it's just...
No, it's just because this is something that is reproducible worldwide. So in other words, if your labs is able to go deeper, and if the people from the labs are telling to you, I mean, it's 0.005% PNH clone, but this is a clone, I'm sure it's a clone, then this is the main message and the same message. If there is a PNH clone, the reason of having an inherited disorders, the frequency is very rare. So that's really helpful at the clinical status, but I cannot write this because then you might have some countries that don't have this level of deeper PNH clone assessment. So that's the reason why we are using usually this 1 to 2% clone to avoid any misunderstanding. And it's not even a matter of countries, because even in France, there is some centers, for example, that below 1% cannot be sure if it's a clone or not. So if your labs are sure, then it's the same meanings.
One more question. So the most challenging, at least in our setting, to treat are the very severe aplastic cohorts, particularly when we are putting them on the non-transplant IST based arm. Even in your graph which you showed, that the time to respond is usually beyond 3 months. So do you still think that in very severe aplastic anemia cohort who do not have a matched donor, is it worthwhile to take them to the haplo or mismatched transplant arm rather than attempting an ATG arm?
Yeah, so I think that, so this is a slide here. Yeah. I think that we are not waiting. I'm just sharing this because it's important. We are not waiting more from 3 to 6. You see here the 66% in the standard arm and the 76% in the experimental arm, 3 months. And then when you go to 6 months, 66 versus 78. So just to say that we are not gaining a lot between 3 and 6 months. So more and more, we are taking decision at 3 months. Then the way we should approach the new treatment, first of all, we should absolutely eliminate an inherited disorder and a clonal evolution. I'm repeating myself, but we should always put us being humble and knowing that sometimes we're missing diagnosis. So first of all, be sure of the diagnosis. And then I think that for refractory patient at the moment, the best treatment is transplantation. But then came to the field, which condition? So of course, in the older patient with comorbidity, it's difficult. So then if the question is, should I add something between 3 and 6 and not waiting 6? Yes, you will have some patients who respond later, but they are very, very few. So you could add outside transplantation something between 3 and 6 months. But again, don't forget the misdiagnosis and the treatment, that the best one is transplant.
Yeah. So the response rates of ATG-IST among the very severe ones versus severe ones, are they different or are they same?
Alors, the response rates are different between severe and very severe because the severity was associated with a lower response, so they're responding lower, but the difference of response was the same with L-Thrombopag. So in other words, you have also lower response rates in severe patients with L-Thrombopag. And what we do show is that this lower response rate was lower in a way, so you are benefiting even in very severe patients of L-Thrombopag compared with standard treatment. But anyway, the patients with very severe aplastic anemia are responding lower. The two main factors is severity, very severe, and age, more than 40.
Thank you, sir.
Thank you, Dr. Arihant. Dr. Prashanta, your question, please.
Yeah, very good morning, sir. It was a very informative talk. I have two questions. One is regarding the PNH clone. At what cutoff of PNH clone you don't advocate ATG cyclosporine therapy and go for a transplant or other supportive care?
So we are not considering a PNH clone as an indication for treatment. It's more, as we were discussing before, a diagnosis marker. So basically, that's the discussion we got. If the overlaps, people are saying that the PNH clone is even less than 1%, but present, it's very important for the diagnosis. Then for the treatment, we are not considering PNH. If we are, of course, there are some patients with aplastic and PNH, or the PNH is not hemolytic, so you don't have any LDH and so on, and then we are proceeding to aplastic treatment if like not PNH patients. If there is an hemolytic PNH, then we might add, of course, a complement inhibitor at the top of the treatment. But you can see things both ways. So you have the indication for aplastic treatment and the indication for PNH treatment, and the treatment might mix together. There is no problem if needed.
Thank you, sir. Now, one more thing is that some of these patients also have a coexisting renal failure. So in that kind of a situation, do you still advocate cyclosporine with the dosage adjustments and more stringent renal monitoring? Or would you switch to another immunosuppressive drug like mycophenolate?
So
clearly, mycophenolate adding is no benefit here.
no, yeah. So no, so cyclosporine is really detrimental in aplastic anemia. What we are doing is trying to give some, but outside toxicity. So if the patient has a kidney failure, most of the time we are not using it because we cannot risk to lose the kidney. If the patient is presenting a kidney failure, we are trying to decrease the dose. So in other words, in patients with kidney involvement, we are not targeting a level of cyclosporine, but targeting the highest dosage the patient is supporting. And then there is no drugs to replace cyclosporine. We try the tacrolimus, which is not less painful for kidney. And mycophenolate mofetil has been shown not useful in aplastic anemia, so we're not giving it. Sirolimus is the same, not useful and possibly associated with TMA. So not using cyclosporine is a real nightmare. And Trombopag really helped because at least we had this. But of course, with cyclosporine, it's always better.
Would you add danazol in that case?
Yeah, we're also using danazol when we cannot use cyclosporine. So most of the time, don't forget that ATG itself might be helpful. So, and this is the reference treatment. So we are first going through this, and then of course, if the patient is still refractory, we're using danazol, we're using eltrombopag and stuff.
Thank you, sir.
Thank you, Dr. Prashant. Dr. Sanjukta Rao, your question.
Good afternoon. Thank you so much for your talk. I have a few questions. One, from your talk, do you recommend monitoring with a bone marrow for clonal evolution if patients are on eltrombopag? And if yes, at what point, even if they are in CR? That is question number one.
So marrow aspiration, we are systematically doing every 18 months in all our patients. So this is obviously not very easy, and this is sometimes painful. So we are trying to do it the right way with anesthesia. I mean, not general anesthesia, but trying to do with some helps from drugs to make the patients be relaxed. But we are doing it systematically, especially in patients with eltrombopag exposure. We have some clonal evolution in complete response patients, even if they are lower. And then it depends about tolerance of the patients, because of course we all have some patients that cannot stand a marrow aspiration. And we're also developing some new tools to try to have some peripheral clonal evolution assessment in the blood with a molecular approach. This is, again, the research for the moment, and it's not on a routine. So I would say, yes, we are trying to do some regular sampling the way we are doing with hospitalization and stuff, I mean, daily hospital. But sometimes, as you are saying, if the patient is in complete response, the CBCs are stable, then of course we're taking a little bit more time because we know the patients are very reluctant to this approach.
Thank you. Question number two is, how are you treating aplastics in pregnancy and lactation? Is there any safety of amiplastin in that setting?
So we don't have a clear idea of thrombopoietin receptor agonists in case of pregnancy. So we are not recommended to women to be pregnant while being treated with eltrombopag or romiplastim. Sometimes, of course, we are doing it at the very late stage of pregnancy, but not for aplastic anemia, but because of ITP and in dramatic situation. But most of the time, we are not using TPO receptor agonists in this situation. While on the other side, cyclosporine is not a problem.
My last question is, do you think there's any role of a telomere length testing to know whether the patient will respond to immunosuppressive therapy?
So that was something identified in the NIH study, showing that patients with longer telomeres are responding better to eltrombopag. We did not confirm it. I think that telomeres must probably be more on the diagnostic stage when you're thinking of an inherited disorders, and if are not moving to a gene panel, but they should not predict any response for the moment.
Thank you. That's all.
Thank you, Dr. Sanjukta. Dr. Alka, your question, please.
Thank you, Professor, for such an illuminating talk. So I have one or two questions to ask. Part of the question has been already asked by Dr. Sanjukta, but taking forward from there, I just would like to know whether you would do bone marrow after the patient has responded and you are now you're planning to stop therapy, or you have stopped therapy and you will be doing bone marrow or not at this point of time. And the second question is, suppose the patient has responded and after 2-3 years again relapses and is transplant not eligible, and bone marrow doesn't show any clonal evolution or progression to malignancy. So what would you recommend to start therapy again with cyclosporine and eltrombopag, or first you would try to start with eltrombopag, then if you don't find a satisfactory response, then you will add cyclosporine, or if you don't find any good response to eltrombopag after 1 or 2 months, then you would like to add again immunosuppression. These are my two questions.
So the first question is basically to know if we are still doing follow-up at the marrow level if the patient is not treated anymore. So the response is yes, the patients are followed lifelong, and we are trying to do the best way. I mean, because again, this is a very painful exam. And the second question is something that I should have precised before, is that relapse setting is very different from refractory setting.
Yeah.
A patient who is relapsing, you may have a new robust response with immunosuppression. So most of the time, if we cannot offer transplant, because if you can offer transplant, then you should go
That
to
is
transplant.
fine.
The same way of refractory patients. But if you have to go to immunosuppression, honestly, I will try to go to what the patients had before, because he might respond again. And we had some patients that responded, there is some sustained response lifelong. So I will really go for the combination because again, the relapse is really different from refractory, and they might very well respond afterwards.
Thank you. Another question, just a simple thing. Do you monitor for viral reactivation during this immunosuppressive therapy?
For
like for CMV reactivation or EBV
no.
reactivation?
No. So that has been published by Phil Scheinberg. It's a blood paper, 2007, I think, where they monitored to see what's going on without treatment, all aplastic patients at NIH, 300 patients. And in terms of viral reactivation, there is no need of monitoring because you will not have to be worried about any disease related to it.
So just in addition to this, so for how long you add prophylactic antimicrobials when you are giving immunosuppressive therapy? Do you add antibacterial, antifungal, and antiviral? And if you use it, then for how long we should be continuing it?
So for the antifungal, we are just reaching 500, 0.5 giga per liter neutrophils.
Yeah.
For the antibiotics, usually we are saying 6 months, but we know that the patients are not very compliant, and the same with acyclovir. No, 6 months, 2 years, sorry, 2 years. But we know that the patient is not very compliant, and most of the time they're coming to our clinic saying that they don't take it, but usually it's 2 years.
Thank you so much. Thank you so much, Professor.
Thank you, ma'am. Agarwal sir, your question, please.
Wonderful talk, sir. Thank you so much. In equivalent doses, all these drugs, the TPORAs, are they equivalent in their efficacy? Eltrombopag, amiplastim, and avatrombopag.
It's difficult to say. First line, we don't know because there have not been clinical trials using romiplastim at the setting of Aplastic, because basically the eltrombopag data were already out. So there is no data to answer to this question in first line patients. In second line patients, yes, we can answer. And when we are using higher dosage of TP receptor agonist romiplastim 5 to 10 and higher dosage of eltrombopag, because again 150 is twice the dose we're using in ITP, the expecting response is the same. Yeah, it's about, I would say, 40 to 60% response rates in refractory patients.
Avatrombopag dose will be 60 mg.
I'm sorry?
The dose of avatrombopag will be 60 mg per day?
Yes, exactly. But I don't have experience with avatrombopag because we don't have access to it.
Okay.
And this is a good point. There is also the Diamond study from Australian colleagues who were using avatrombopag first line at the top of cyclosporine and ORS-ATG, but I did not see the results yet. But it might be published. I didn't see it. I know that they were presenting it, I think, at TBMT or last ASH, but I don't have the paper.
Right. When you have chemotherapy-induced prolonged cytopenia, do any one of these drugs help in any way or just support therapy?
No, it might be helpful in, I would say, really well prolonged, because most of the time this is patients who might have some bone marrow failure disorder behind. So when we have 2 months of cytopenias, prolonged cytopenias post-chemo, then it might be helpful to use eltrombopag. That's what we are doing sometimes, but it's exceptional cases.
Right.
Yeah, we are also doing in cytopenia post-transplant. We published this in Blood 2018, I think. Romiplastim at 5 microgram per kilo post-transplant, if the patient is full chimerism, no viral infection, no toxicity, that might be very, very helpful.
Eltrombopag and androgenic hormones, both are hepatotoxic. Can they be combined together?
So we didn't do, honestly. Then in very severe patients, it might be an option. Well, it's always the same, you know, that you can test for, we can do some liver test and then you see what's going on. In very, very dramatic situation, I mean, I could not say don't do it because, I mean, we don't know what to do and we want to help. So if you just look for liver test, it might be possible.
Those who get liver problem with eltrombopag, we can switch to romiplastim?
Yeah. The toxicity is less with romiplastim.
Same applies to thrombosis. If somebody gets thrombosis with eltrombopag, can we switch to romiplastim?
So the answer is yes, but then we're entering in another thing, is that you have a thrombosis with a triple receptor agonist. We didn't have any problems in the race trial. We didn't have any problems in all the disease we did. So at the moment, it's a green light. But I'm not sure that you will not be exposed to the same problem in case of romiplastim, because it might be related more to the thrombocyte counts than to the drug itself.
Thank you, sir. So there are some questions from the audience. Question from Dr. Naresh Tayade. He has asked question on breakage analysis test in Fanconi's. Till what age group should we go for chromosome breakage analysis test? That is the question.
So we are doing it in pediatric patients because this is a very simple test and is coming further and quicker than the gene panel. But I should confess that in most patients at the moment, we are doing the gene panel anyway, because we do know that we have many diseases that are not always associated with growth retardation, with organ dysfunction, with abnormal physical signs. So So we are proceeding to gene panel, but we need at least 4 weeks. But breakage test and telomere lengths might be very helpful because, of course, if it's positive, then you have a diagnosis.
So would you say that chromosomal fragility test is more reliable, more comprehensive than the NGS panel for Fanconi because there are too many mutations?
No. I'm saying it's quicker. That's all.
But fragility, chromosomal fragility test will be more reliable, right?
Yeah.
Okay.
So, sir, if chromosome fragility test is negative, then should we go for NGS?
So we are using the NGS to have the more overall panel, all the genes related to BMF. So if it's not Fanconi, it might be something else.
True, sir. So there's a question from Dr. Shyam. How do you manage severe aplastic anemia with renal failure that you already answered? So between the three drugs, avatrombopag, L-thrombopag, and romiplostin, which is the best TPO according to you?
I think there is no best drugs. They should work the same because this is the same class of drugs. What we have is more data with L-thrombopag. So that's the reason why, in a way, we are more comfortable using it because we have more data on response, we have more data from randomized trial, we have more data on long-term follow-up. But just because we have more published data, this is it. But the class of the drugs are the same.
Thank you, sir. And any benefit of combining two TPO receptor agonists in refractory aplastic anemia, as the two can have this different mechanism, like romiplostin plus L-thrombopag, like that?
No, I don't think it's something we should do. We can probably switch from one to another if we think that it might be helpful and if the patient is really refractory to everything. But to use at the same time, we don't know what's going on and what's going what, so it's a bit difficult.
And in real world practice, what is the percentage patient being cured in long term on ATG plus cyclosporin plus L-thrombopag?
Very few. It's about 15 to 20%, no more. As you know, that when the patients are responding, they might relapse, they might be exposed to clonal evolution, not only MDS and AML, but also PNH. So the idea of giving immunosuppression is to have a quick response and to be as much as possible transfusion independent, to be far from the hospital. But we do know that in the end, there will be only 2 out of 10 patients who will probably benefit from this combination. That's the reason why transplant is still the best treatment for aplastic anemia, but with the balance of age, comorbidities, donors, and stuff.
Thank you, sir. And what is the upper age limit of ATG therapy?
No age limit. So this is not an age limit. Age is not a limit per se anymore. So what is limiting is comorbidities. And we have some patients at 40 years of age that have kidney insufficiency or cardiac failure that we could not give horse ATG. And on the other way around, we have some patient. Last one was a lady, 75 years old. She was doing great, no comorbidities, still running. I mean, we give her ATG and there was no problem. So we published this, I think it was 3 years ago in Hematologica, showing that age per se is not a limitation. That's very important for patients to give ATG.
And if the patient is elderly, can we decrease the dose from 40 mg to 25 mg per kg? That can be done.
I would say no, because you don't know what you're going to do. So in other words, the data has been generated and published using the dose of 40 milligram per kilo for 4 days. And so you won't know what's going on, or if the dose is not enough, or if the patient. So I would definitely go or not go, or you go with the standard dose, or you don't go.
Thank you, sir. Another question from Dr. Prakash Tiwari. Any comments on post-COVID pancytopenia mimicking aplastic anemia?
Well, we didn't have higher rates of aplastic anemia post-COVID related or to infections related. So we did this study. It was published in Hematologica. It's 365 patients. It was the vaccines that we were testing, and we didn't have any bad feedback with the vaccine. For the COVID, I mean, it's acting like a viral infection, CMV or rhinovirus or whatever. So you might have some of course, patients with cytopenias, but then they're recovering outside the COVID.
Thank you, sir. Another question from Dr. K.K. Radhika. Aplastic anemia with a PNH clone of more than 30%. With only ATG plus L-thermopeg is sufficient, or can we add steroids or danazol with this to have a maximum benefit?
So the PNH clones should not influence your decision on the treatment of aplastic anemia. So in other words, it's not because there is a PNH clone that you should use danazol or androgens. The PNH clone might be treated with complement inhibitors, but if there is some hemolytic sign, but it should not influence your treatment of aplastic anemia. That's nothing to do.
Thank you, sir. Another question from, again, Dr. K.K. Radhika. If once we initiate our patients on L-thermopeg with 150 milligram upfront, majority of them are not tolerating this dose of 150 milligrams, and some of them have the complication of hepatic dysfunction also. So can we reduce the dose from starting point only in Asian population? What is your opinion?
Yeah, there is some patients that are not tolerating 150, but are doing good until 75. So yeah, there is some patients that we might have some effects on 75 milligrams.
Thank you, sir. And another last question from Dr. Ali Dinky. And first of all, she has congratulated for that fantastic talk. And she has asked you to shed more light on relationship between malnutrition and aplastic anemia. And will there be any difference in the management if the patient is more malnourished?
Yeah, so of course there is some cytopenias in really bad nutrition patients, but this is another question. I mean, this is not the same process, and I guess that first of all, yeah, we should proceed with a well nutritionism for some months to see if the things are recovering before thinking about the plastic. But this is really another question, and we should not mix. And yeah, we can imagine that the patients after some months, if he's not recovering, then we are proceeding to aplastic anemia statement.
Thank you, sir. Another question from Dr. Akanksha Garg. What are the results of mesenchymal stem cell therapy in aplastic anemia?
Very heterogeneous. Case report only. No randomized trial. Gut feelings.
Thank you.
I cannot say more.
Thank you, sir. Dr. Ariyat Jain, your question?
So, sir, first of all, thank you once again. The other question is, whenever we are classifying as response, we tend to differentiate between PR and CR. A lot of times, most of these patients post ATG cyclosporin L-thrombopag have a robust response, but their platelets are kind of somewhere between 80,000 or 90,000, and we end up calling them as a PR, even if they are sustained over, say, few months. So is there a difference between PR and CR in the long term in terms of relapse rates, and do we change our duration of immunosuppression or cyclosporin maintenance if in a patient who has a PR versus a CR? So are these two prognostically different, is what I wanted to know.
So I agree with you. There is some patients that have 90 gigaper platelets. I mean, they should not be considered as CR, but they are not far. So it's quite the same. I mean, it's always in medicine very difficult, to dichotomize, and sometimes we are a bit rigid. What I can tell you is that for a true partial responders, let's say 40,000 and not to be clear, yes, there is a high rates of clonal evolution in refractory patient compared with patients in response, but we do not know if there is a high rates of clonal evolution in partial versus complete. At the moment, we should probably have this data because there is more patients in complete remission than before, but for the moment, we don't have those data. The follow-up is the same. And for immunosuppression, I agree with you that sometimes in some patients, we see they're reaching a good platelet counts. We see that it's continuing to increase a bit from 85, 90, 95, from a clinic to another, they are still increasing. For those ones, I agree. I still go for full immunosuppression until they reach the best level and very stable level. When it's very stable, then after a while, 3-6 months, I'm decreasing. But I agree with you, we are trying, and I have some patients that are full dose, let's say for 18 months or 2 years, because I see that we're gaining each time. So yeah, and then afterwards I'm decreasing. So yeah, I mean, as you may imagine, I'm not proceeding only like what I'm writing in textbook, like everybody. There's also some experience and clinical practice.
So are the PRs having higher relapse rates as well? You told about clonal evolution. Are they having higher relapse rate as well?
This I can say yes, but I don't remember where this data came from, but we look for, with you have a complete remission. I mean, for clonal evolution, we know it's less, but we know it's responders. For partial, yes, there is relapsing more, but it's not published yet, but it's, I think, in the race abstracts.
Thank you.
Thank you, Dr. Regan. And just last question just popped up, sir. A regard from Dr. Udani Kothalawala. She wants to know about whether you really recommend L-thrombopeg in children with severe aplastic anemia. And if yes, what would be the dose in children?
So no, I'm not recommending to use L-thrombopeg in children. First of all, because they are almost all eligible to transplant, and that given L-thrombopeg to them will possibly avoid transplantation. So in other words, we do know that they are not going to respond better. And we know that those kids are going to expose to their disease for years. So we try, if there is no match unrelated donor, no sibling, we try our cytidine cyclosporin, and at 3 months, if it's not working, we go to transplant. And I would say for kids, whatever the donor is, even cord blood. We publish cord blood transplant for those patients. Kids patients was 2018 in blood, and the overall survival was 90%, 3 years. I mean, kids are really less toxic than adults looking for transplant, and at least they get rid from the disease, they get rid from clonal evolution, PNH, MDR, CML, cyclosporin dependence, and all those things. So yeah, if they are not responding straightforward, we have to transplant.
Thank you, sir. I've finished all the questions from the audience. Any discussion want to ask any other question? Dr. Alka, yes, please go ahead. Alka, yeah.
So I just wanted to know about, like cyclosporin, we have a protocol to decrease by such percentage and we stop by 2 years or so. What is the protocol for decreasing L-thrombopeg?
Yeah, so for L-thrombopeg, we got the best response, and then we are decreasing the dose by half for 2 months. There is 2 ways. Okay. The real way, I mean, published and we have data, it's to decrease the dose for 2 months, halfway, and then we are stopping to avoid hiring the risk of relapse. Honestly, in the clinical practice, what we're going at the moment is coming from 150 to 100 for let's say 16 weeks for 2 months, and then 100 from 50 to the same 2 months, and then stopping, because honestly, we know that when we're stopping quite quickly, the patient is relapsing. Yeah. So that's the reason why more and more we are considering in a little bit like cyclosporin and trying to decrease slowly.
Thank you.
But this one is not published. It's very recent and it's more in the clinical practice.
Because I also do like this. That's why I wanted to know whether you also taper it like that way. Yeah. And I've seen while tapering L-thrombopeg, their counts will again fall. Then when I increase, then they will again reach their adequate levels.
Yeah, there is a new disease in a way. It's L-thrombopeg dependence, and yes, there is a meeting in Genoa next week. No, so not this one, but the week after, on behalf of the BMT. And I mean, of course, it's far. I'm not sure it's something by Visio, but anyway, we are addressing this, especially this L-thrombopeg dependence, a new term of this situation.
Thank you for your input. Thank you.
Thank you, ma'am. So there are 3 more questions which just came up. I'm just asking you 3 more questions. After a question from Dr. Ali, any chance of spontaneous resolution of aplastic anemia, especially in children?
Of course. That's the reason why we're not treating everybody. You have some patients that have mostly moderate aplastic anemia. And then if they are not transfused, we are following them. And of course, it's not much, but about 5% of those ones, 5 to 10%, will have slowly have increasing counts and coming back to normal. And then you don't see everything. So yeah, that's might happen.
Thank you, sir.
This is a dilemma. This is a dilemma between US colleagues who are treating all moderate patients transfused or not, and us in Europe thinking that sometimes we could wait a little bit, and then they are telling to us, yes, of course you have spontaneous remission, but on the other side, you are making the stem cell being destroyed, and then you might have no response to immunosuppression. So this is a dilemma by treatment, not treatment, benefit risk, and medical practice.
Thank you, sir. Another question from Dr. Hitabi. Sir, there is any role of steroids in PNH? And if yes, what is the maximum dose of steroids you can use in PNH?
So steroids should not be used in PNH when you have access to complement inhibitors, because steroids has been shown to be associated with infection in the French registry without avoiding PNH complications such as crisis, thrombosis, and whatever. And on the other way around, there is a nice case report from Alexander Roth from Essen, who showed, I think it was 10 years ago, who showed a patient who received 15 years of steroids in PNH, and she did all the PNH complications, but she did also all the steroids complications with Cushing syndromes, diabetes, blood hypertension, hypertrophy, and so on. So steroids, I mean, if you have access to complement inhibition, should not be used in PNH.
Thank you, sir. And another question from Dr. Priyanka Srivastav. Those patients who are not eligible for transplant, not eligible for ATG, have you used 3-drug combination, all oral, danazol plus cyclosporin plus eltrombopag in your clinical practice? And if yes, what is the response?
So no, we are not mixing drugs for the moment, and we don't have this experience so far. So what we are using is cyclosporin plus eltrombopag, because we know that they are synergic, and it's always better both together than one and one. And then if this patient is not responding 6 months, we're switching to Danatrol. Danatrol is a bit difficult in all the patients because sometimes male have some prostate problems. So this is a way that sometimes we cannot use, but in female, it's okay.
Thank you, sir. And exactly after 6 months, you stop eltrombopag? ATG?
This is clinical practice. So it might be 6, it might be 9, depending the patients, if you have no response at all, or if you begin to have something, there is something that, it's just experience.
Thank you. And
but, if you have some difficult patients, I see that I have an email from an Indian colleague. You just wrote to me, and then we discuss, and we can just, exchange and take the best decision we think for the patients.
Thank you, sir. And another question from Dr. Karan Ramamurthy. If the patient is cyclosporin and eltrombopag dependent post ATG, can you continue these 2 drugs for more than 2 years?
We have some patients that are receiving eltrombopag since 8 years. Sometimes this is the only combination that is helpful. At least the patient is free from transfusion. The only thing, again, is that then you have really to be very careful with marrow and doing marrow aspiration regularly. And even for marrow aspiration, I was very systematic in my clinic last Wednesday with the patients, speaking about marrow aspiration and stuff, and she was 75 years old. And I thought, well, in a way, it's not going to change anything because I'm not going to offer transplant. So you see, sometimes you have to be a bit realistic. So if these patients you're speaking about might be eligible for transplant, obviously, sometimes you're more prone to go for cyclosporin rebolide than a haplo transplant. But if you're doing this and you think that you might give transplant at these patients, you might look for the marrow. And then for the old patients with comorbidities, that you will never go to transplant. Marrow aspiration might probably be avoided. This is a complement to my answer to the questions before. We obviously have to be realistic.
Thank you, sir. So any discussants want to ask any other question? Well, so sir, thank you so much for that, again, fantastic, lovely talk. Wonderful discussion.
My pleasure. And we will meet in January, I think.
Thank you so much, sir. Thanks a lot.
Bye. Bye-bye. Have a good day all. Bye-bye.
Thank you. Bye-bye.